Hello once again and welcome to another lecture series. This is going to be cardiology for internal medicine. I'm going to be doing about maybe 3 hours worth of this. It might go a little longer. So these are all based on my UWorld notes, and I've tried to make it as complete and concise as possible. This lecture is it's a nice audio lecture that's good for just being in the gym or in the car, and you have just access to information, and all this is high yield information taken directly from UWorld. So I think it's a good beneficial tool for you and for myself. So let's get started. So the first topic is going to be evaluation of chest pain. And there's a pretest. First of all, you're going to ask yourself if there's a pretest probability of coronary artery disease. And that's going to be due to the severity, if it's low severity, if it's intermediate or high. So let's say somebody has chest pain. What are their probabilities of them actually having coronary artery disease? If it's low, meaning a young person or somebody who do you think is pretty healthy, then no additional diagnostic testing is needed, because high risk, the high risk can give you a false positive result. However, if you have a high suspicion of coronary artery disease with chest pain, you want to immediately start pharmacological therapy for coronary artery disease. And you also want to consider going straight to the cath lab and doing a coronary angiography. Now, however, most of these patients are going to fall in the category of intermediate, and if you might think they might have probabilities of coronary artery disease, and they present to you with chest pain, then you want to ask if they're able to exercise. If they're not able to exercise, you want to go ahead and do pharmacological stress imaging tests, and then if that pharmacological imaging test comes out positive, then you want to go straight to coronary angiography. However, if they are able to exercise, which might be, again, the majority of the cases, then you want to do an EKG. If the EKG comes back positive, meaning that there is something going on with the coronary arteries, then you want to do an exercise EKG test. If the EKG test comes back positive again, then you want to go straight to coronary angiography. But if you do that first EKG and it's normal, then you want to do just exercising imaging tests while they're exercising and check out their imaging. If it's positive, then you want to go straight into coronary angiography. So what are some of the pretest probabilities of coronary artery disease? We already said it. If it's low, this would be an asymptomatic patient of all age ranges, and they present to you with atypical chest pain, specifically in women that are younger than 50 years old. Intermediate is going to be 20 to 80% probability, and that's your atypical angina in men of all ages, as well as atypical angina in women that are greater than 50 years old, and typical angina if it's a woman between the ages of 30 to 50. A high pretest probability of coronary artery disease is going to be your typical signs of angina in a man more than 40 years old, or typical angina in a woman that's greater than 60 years old. So as you can see, in a woman, you want to start off at 50 years of age. If they're younger than 50, most likely it's not going to be a pretest probability of CAD. However, if they're greater than 50, then you're starting to think they might have it, and if the angina is typical, then there is a very high chance that they might have it. So what are some of the classifications of angina? You have typical qualities are going to be like chest pressure or crushing pressure, and the duration usually lasts more than 20 minutes. It's probably provoked by exercise or emotional upheaval, and it's also relieved by nitroglycerin or by just resting. Those are your classic angina characteristics. Atypical angina would be chest pain with two of the classic angina characteristics. And non-anginal chest pain would be chest pain with 0 to 1 with none or just one of the classic angina characteristics. So what are some of the evaluations of chest pain in the ER? So you want to do a focus history and physical examination first. You want to check vital signs, and you want to obtain venous access. Then you want to see if the patient's stable or if it's not stable. If they're not stable, you want to immediately stabilize them with hemodynamic control, give them IV fluids, or you want to check for any kind of underlying causes. And you want to check for underlying causes. Now, however, if the patient is stable, then you want to obtain an EKG and do a chest x-ray. At that point, if the risk for aortic dissection is low, then you just want to administer aspirin. And you also want to give them oxygen. If the EKG is consistent with acute coronary syndrome, then you got to see if it's either an ST wave elevation MI or if it's a non-ST wave elevation MI. So a STEMI or a non-STEMI. If it's a STEMI, you want to treat with emergency catheterization, or you want to give them thrombolytics. If it's a non-STEMI, you want to treat with the appropriate anticoagulation. Now, if the EKG is not consistent with acute coronary syndrome, then you want to ask yourself, is the chest ray diagnostic? If it is, then you want to just treat what's causing the chest pain. If the chest x-ray is not diagnostic, you want to check and assess for pulmonary embolism. You want to go ahead and check cardiac markers, and you want to risk stratify for acute coronary syndrome. You want to assess for pericarditis as well, and you want to assess for aortic dissection. And remember that aspirin is given before heparin in acute coronary syndrome. Aspirin is going to significantly reduce the rate of an MI. It's going to reduce the rate of a stroke, and it's going to give you an overall mortality in acute coronary syndrome. So atypical symptoms in acute coronary syndrome is going to be like chest pain, dyspnea, nausea, vomiting, epigastric pain. So these are all relative frequencies of selected presenting symptoms in acute coronary syndrome. So the majority is going to be chest pain at 80 to 85%. Dyspnea is going to be 70 to 75, followed by nausea, followed by vomiting, and finally by epigastric pain. And women and elderly patients, as well as patients with diabetes, are going to be more likely to develop atypical symptoms. Up to 20% do not report chest pain at the time of the presentation, and that's going to delay the diagnosis and underlying treatment. So this is an important one. What are some of the medications to withhold prior to a cardiac stress testing? So before you do the stress test, which medications do you want to stop? So in 48 hours, you want to stop beta blockers, you want to stop calcium channel blockers, and you want to stop nitrates. You also, in 48 hours, you want to stop prior to a vasodilatory stress test, you want to stop dipyridamole. And for 12 hours before the stress test, you want to avoid them having any type of caffeine-containing food or drinks. And some of the medications you want to keep them on are ACE inhibitors or angiotensin receptor blockers, ARBs, digoxin if they're on digoxin, statins, or diuretics. Those you want to continue. The ones you want to stop are nitrates, calcium channel blockers, and beta blockers. That is a high yield question. These medications should be continued with those with known coronary artery disease to assess efficacy of anti-anginal therapy. And the decision to withhold the medication should also be carefully tailored to the individuals to minimize the risk of rebound hypertension or arrhythmias. So what is a differential diagnosis of chest pain? So what can mimic chest pain basically? So coronary artery disease the way it presents is that it's a substernal pain. It can radiate to the arm, to the shoulder, or to the jaw. It's precipitated by exertion, and it's relieved by rest or by nitroglycerin. Pulmonary or pleuritic chest pain, like in pleurisy, in pneumonia or pericarditis or a pulmonary embolism, these present with sharp stabbing pains. So if you see sharp stabbing pains, a patient's complaining of sharp stabbing pain, think of pulmonary causes or pleuritic causes, as well as worse with inspiration. That's a big one. Pericarditis is going to be pain that's worse when they lie flat. A pulmonary embolism or a pneumothorax is going to give you respiratory distress as well as hypoxia. Aortic pain would be like an aortic dissection, an intramural hematoma. These are sudden severe tearing pain. So if it has to do with the aorta, you're gonna see in the vignette that the patient presents with a sudden severe tearing pain that radiates to the back. Look for an elderly man with hypertension, and there's risk factors for atherosclerosis. Then you have your GI symptoms. Gastrointestinal and esophageal causes would give you non-exertional pain relieved by antacids. So they'll give you the picture of non-exertional pain. So you might be thinking, oh, this might be an unstable angina. But then they tell you that he took an antacid and it went away. Now you can go towards GI problems. They also have upper abdominal or substernal pain, and it's usually associated with regurgitation, with nausea, as well as dysphagia, and they have nocturnal pain. So pain at night. And that is high yield. That's actually one of the biggest high yields for a differential, is they want you to know GI causes. Chest wall and musculoskeletal causes will give you persistent or prolonged pain, so pain that's for a very long time. Worse with movement or changes in position. That can actually look like pulmonary, so be careful with that. But it's often followed by repetitive activity. So activity, prolonged pain, and worse with movement. You're thinking muscles, musculoskeletal, chest wall muscles. So yeah, those are going to be your differentials of chest pain. Features suggesting esophageal disease are going to be a prolonged pain that lasts for more than an hour, postprandial symptoms, so it's usually pain after you eat. It's associated with heartburn, dysphagia, and again, there's relief of the pain if they take antacids. So the next one is, what are the treatments for stable chronic angina? So anti-anginal pain can be, or medications can be beta blockers, calcium channel blockers, and nitrates. So that's why those are the three, remember, that are stopped before you do a stress test. And the reason here is that you don't want to stop them from having pain. You actually want to induce them to have pain. So beta blockers are anti-anginals. These are first-line therapies for anginal symptoms, and it improves exercise tolerance. So don't you see why this will skew a stress test? That's why beta blockers are stopped. It also relieves angina by decreasing myocardial contractility as well as heart rate, and it improves survival in those with myocardial infarctions. Calcium channel blockers are also anti-anginal, and they can combine with beta blockers if the angina is going to persist, or as an alternative therapy. And as well, it improves the angina by causing peripheral or coronary vasodilation. Nitrates are short-acting forms, and these are used in acute settings. A long-acting form is an add-on therapy for persistent angina. So nitrates are never going to be a long-term. They're going to be for angina aborting symptoms like now. Prevention for angina would be aspirin, statins, to stop smoking, regular exercise and weight loss also control blood pressure and diabetes. Next topic is your variant Prinzmetal's angina. So this is common in young women, and it's the greatest risk factor is going to be smoking. There's atherosclerotic risk factors that are usually absent. So there's usually not any type of atherosclerotic risk factors. Episodes are very common at night with Prinzmetal's angina, usually between 12 a.m. to 8 a.m. It's also after they exercise. It's also if it's associated with hyperventilation, as well as emotional stress, cold exposure, or if they've been using cocaine. There's a transient ST wave elevation, and then that returns to baseline. Unlike an ST wave depression and unstable angina, and longer durations of ST wave elevations in a real MI. So how do you treat Prinzmetal's angina? This is just caused by a spasm. So during the spasm, you lose blood flow to the area, causing you pain, comes in waves, comes and goes. So you want to stop the spasming. How do you stop spasming? By giving them a calcium channel blocker or by giving nitrates. All right, so next topic is going to be an MI, myocardial infarction. So myocardial infarction location based on coronary vessel involvement. So what's the part of the myocardium involved, the vessels that are blocked, and what it's going to look like on the EKG is what we're going to go over right now. So for the anterior MI, so let's say somebody has an anterior MI. The vessel involved in an anterior MI is the LAD, the left anterior descending. And the EKG is going to show either some or all of the leads between V1 to V6. So V1 to V6, left anterior descending, that's an anterior wall MI. And it's in the name, left anterior descending, anterior MI. Leads V1 through V6. So next one would be an inferior wall MI. This is either your right your right coronary artery or your left circumflex. The ST wave elevation here are going to be your leads 2, 3, and AVF. So always remember that for the right coronary artery, it's ST wave elevations in leads 2, 3, and AVF. And it's an inferior wall MI if the right is involved, as well as the left circumflex. A posterior wall MI is going to be also your left circumflex or your right coronary artery, so be careful there. But these can give you ST wave depression specifically in leads V1 through V3. If it's the left circumflex, then there's ST wave elevations in leads 1 and AVL. So that's elevation in leads 1 and AVL in a left circumflex, versus in a right coronary artery involvement, you'll have ST wave depression in leads 1 and AVL. So ST wave elevation in left circumflex, ST wave depression in the right coronary artery, and both are going to be leads 1 and AVL for a posterior wall MI. All right, for a lateral wall MI, again, is your left circumflex or your diagonal marginal branches. This is your ST wave elevations in leads 1, AVL, V5, and V6. And then you'll also have ST wave depression in leads 2, 3, and AVF. So 2, 3, and AVF, remember that was associated with the right coronary artery, which is an inferior wall MI, but this is elevation. That would be elevation of leads 2, 3, and AVF for a right coronary artery. If it's ST wave depression in leads 2, 3, or AVF, then that's your left circumflex or your diagonal, and it's a lateral wall MI. And then you have right ventricular wall MI, and that occurs in about half of the inferior wall MI. So since it's an inferior wall MI, again, that's the right coronary artery, and you'll have ST wave elevations in leads V4 through V6 on the right. Okay. So a right ventricular MI is seen in 30 to 50% of patients with acute inferior wall MIs due to occlusion of the right coronary artery proximal to the origin of the right ventricular branches. An ST wave segment elevation in the inferior leads, so you'll have leads 2, 3, and AVF, and also a transient bradycardia or AV block can occur with an acute inferior wall MI, and that's due to enhancement of vagal tone. They can have JVD, a Kussmaul sign, and also clear lungs, and those are signs of right heart failure. Remember that. JVD, Kussmaul sign, and clear lungs are signs of right heart failure. Then that can lead to a massive pulmonary embolism, which can present similarly to a right ventricular wall infarction. However, an EKG will show tachycardia. They will have non-specific ST wave segments or T wave changes rather than just an ST wave segment elevation. So it could be both ST segment and T wave changes. And there can also be a new onset of a right bundle branch block, or that pattern that's called S1Q3T3. So that would be an S wave in lead 1, a Q wave in lead 3, and a T in lead 3. So if you ever see a new onset of a right bundle branch block, that is a massive pulmonary embolism. Okay, so what is the diagnosis of a right ventricular MI? How do you diagnose that? It's confirmed with more than 1 millimeter of ST segment elevations in the right precordial leads, which are V4 through V6. And then a right ventricular failure leads to a decrease in preload and it's going to result into having hypotension that's worsened with nitroglycerin. It gets worse with diuretics and opioids because those are going to decrease preload. So you want to avoid that. Drugs that slow down the heart rate, like beta blockers, and that decrease contractility, like calcium channel blockers, could be used, but with caution. All right. So in addition to the standard MI therapy, such patients that have basically without pulmonary congestion or low to normal JVP are typically treated with high flow IV fluids, usually with isotonic saline, and that's used to improve right ventricular preload. And that facilitates left ventricular filling because of the Frank-Starling law, as well as IV fluids, which are less likely to help in these patients if there's going to be a JVP elevated. If you see JVP, you don't want to give them too much IV fluids or else you might cause more congestion. So high flow IV fluids with isotonic saline is better tolerated. So an inferior and posterior wall MI is going to be the right coronary artery in the EKG. So the right coronary artery, like we said, that is in charge of your inferior and posterior wall MIs. That's the right coronary artery is going to supply blood flow to the AV node, and hence an occlusion around that area can cause an AV block. So an inferior wall MI is most commonly associated with sinus bradycardia due to an increase in vagal tone within the first 24 hours after an infarction, as well as a decrease in right coronary artery blood flow to that SA node. That also leads to a right ventricular infarction or a right ventricular dysfunction and then hypotension. So remember, a right bundle branch block with inferior wall MI. And also for the massive pulmonary embolism that we said earlier. So in an acute inferior wall MI, this is going to cause papillary muscle dysfunction or rupture, which can occur within 2 to 7 days. Sometimes it's 3 to 5 days, but it could be 2 to 7 days post-MI. And that's going to cause an acute and mitral regurgitation. And the mitral regurgitation is obviously because the mitral valves is held on by the papillary muscle. If you have muscle rupture, that the cords of that leaflet is going to just snap off and flap and cause a regurgitant valve. So excessive diastolic volume overload happens. You'll have elevated left ventricular end diastolic pressure, as well as left ventricular filling pressure, and that's going to reflect back into the left atrium. So this is going to be all cause and effect here because of the elevation in left ventricular end diastolic pressure and filling pressure. That's going to go backwards to the left atrium. From the left atrium, it's going to back up into the pulmonary circulation, and that's going to give you signs and symptoms of congestive heart failure. Unlike in a chronic mitral regurgitation, an acute mitral regurg does not cause any significant changes in the left atrial or ventricular sizes or changes in compliance because it's happening acutely. In a chronic one, it does because it's had time to adapt and change. So ST wave elevations in leads 1, AVL, V2 to V6, and reciprocal depressions in leads 2, 3, and AVF, that is an acute anterior lateral MI due to an occlusion of the left anterior descending. The left anterior descending again supplies the anterior walls of the left ventricle as well as the anterior 2/3 of the septum, and hence an occlusion there can cause a second degree AV block. So what are some of the post-MI complications? So some of them can be right ventricular failure, papillary muscle rupture like we already mentioned, intraventricular septal rupture, and free wall rupture. So we're going to go step by step, one by one, okay? So in a right ventricular failure, the time course, that's acute right ventricular failure. Usually, since it's on the right, it's the right coronary artery that's involved, and clinical findings are going to be hypotension with clear lungs and Kussmaul signs. And on echo, so you do an echocardiography, there'll be a hypokinetic right ventricle because it's infarcted. There's a right ventricular failure. It's not going to have any movement. Hypokinetic right ventricle. A papillary muscle rupture happens acutely, and it can also happen within 3 to 5 days. That's the common one. It's also involved by the right coronary artery, and clinically you'll have acute severe pulmonary edema because of that backup, like we just said, and there could be a new holosystolic murmur as well, because since it's so close to the septum, it could cause something there, or it can just, since it just infarcted the papillary muscle, you'll have not only a regurgitant valve, but just a holosystolic murmur of that valve. So that's a new holosystolic murmur, can be a cause of any type of rupture really, but papillary muscle rupture can be one of them. Then on echocardiography for papillary muscle rupture, you'll have severe mitral regurgitation with a flailing leaflet. A flailing leaflet just means a leaflet that's flapping in the wind, flapping without any type of strings attached. It's not anchored to anything, so it's like a loose sail at sea. So that's a flail leaflet. So next one would be intraventricular septal rupture or intraventricular septal defect. Usually this also happens acutely within 3 to 5 days, and it could be either due to the left anterior descending or the right coronary artery. If it's the left anterior descending, that's going to cause an apical septal rupture, and if it's the right coronary artery, that can cause a basal septal rupture. So again, right coronary artery to do with the inferior portion of the heart, basal septal rupture. Left anterior descending, apical septal rupture. Clinically, they're going to present both of them with shock and chest pain. There could be a new holosystolic murmur, again because there's a rupture involved, and a biventricular failure. And on echocardiography, there could be a left to right shunt at the level of the ventricle because of that holosystolic murmur. There could be a shunt. And obviously there's a step up in oxygen levels between the right atrium and the ventricle because now that there's a connection there. Free wall rupture, ventricular free wall rupture. This happens later on within the first week or two. And usually the culprit here is the left anterior descending, which is the most common. And clinical findings would be shock and chest pain, as well as jugular venous distension and distant heart sounds, because the rupture happens on the wall of the heart, so the blood's going outside of the heart, and it's going to cause like a pericarditis or constrictive pericarditis. So you'll have pericardial effusion with tamponade on echocardiography. And remember that murmurs heard at the left lower borders are usually seen with septal ruptures. So what are some of the complications after an MI? Because we've been talking about hours to days to weeks. So within hours of an MI, there can be a reinfarction, that's hours to days. There can be a ventricular septal rupture, which takes about a week, so hours to 1 week. That time frame, you're at risk for a ventricular septal rupture. From hours to 2 weeks, you can have a free wall rupture where the entire wall of the heart just ruptures out and can cause that. So that goes all the way up to 2 weeks. A post-infarction angina happens between hours to 1 month. So you can have chest pain due to post-infarction causes up to a month afterwards. Papillary muscle rupture, however, happens not hours, but 2 days to 1 week. Pericarditis usually happens between a day to 3 months, and left ventricular aneurysms happen between 5 days to 3 months. So the longer ones are going to be in the months are going to be your left ventricular aneurysms and your pericarditis, as well as post-infarctional angina up to a month. So what are some of the ventricular arrhythmias? So a ventricular arrhythmia, including ventricular premature beats, non-sustained or sustained ventricular tachycardia, and ventricular fibrillation are quite common in the immediate post-MI period. Ventricular fibrillation is going to be the most common cause of sudden cardiac arrest in the settings of an acute MI. It's more than 50% occurs within the first hour of symptom onset. A re-entry tachycardia is going to be the most predominant mechanism responsible, though an underlying mechanism is going to depend on the time elapsed since onset of that MI. An arrhythmia that occurs within 10 minutes of coronary occlusion, that is immediate or phase 1A ventricular arrhythmia. And the mechanism of action is that it's a re-entry arrhythmia. So if you ever see a re-entry arrhythmia, that's usually due to an immediate phase 1A ventricular arrhythmia. An arrhythmia that occurs within 10 to 60 minutes, so basically within a minute to an hour after an acute infarction, that would be a delayed or phase 1B arrhythmia. So the mechanism of action is that there's an abnormal automaticity. So re-entry arrhythmias, remember that's very fast, within 10 minutes, sorry. So re-entry arrhythmia within 10 minutes, and then delayed arrhythmias are delayed there, and it takes about an hour after an infarction. So a ventricular free wall rupture, the majority of ventricular free wall ruptures, those occur after an anterior wall MI. An abrupt left ventricular rupture is going to lead to a hemopericardium and eventually cardiac tamponade. Because of the tamponade is going to compress the left ventricle, and it's going to decrease stroke volume. And because you have a decrease in stroke volume, there's going to be a compensatory sinus tachycardia. Now, severe mechanical compromise can rapidly progress to pulseless electrical activity with an EKG showing low voltage of electrical activity. A left ventricular free wall rupture should be suspected in cases of a recent MI and no signs of heart failure. So rapid diagnosis with an echo and supportive care, as well as pericardiocentesis and possible surgical repair, are going to be needed to save a person's life. For ventricular aneurysms, the hallmark EKG findings are going to be persistent ST wave elevation after a recent MI and deep Q waves in the same lead. So if you see ST wave elevations throughout the whole entire EKG, that's your ventricular aneurysms, as well as deep Q waves. So if you see a very deep Q wave, think of ventricular aneurysms. So a large ventricular aneurysm can lead to progressive left ventricular enlargement, leading to heart failure, refractory angina, ventricular arrhythmias, and mural thrombosis that lead to systemic embolization. A progressive left ventricular enlargement can lead to mitral regurgitation, again because the heart expands and those leaflets are going to expand along with it, causing there to be an opening and those leaflets to be separated, and suddenly now you have mitral regurgitation. An echo is done to confirm that, and that's going to show a dyskinetic wall motion of a portion of that left ventricle. All right, so papillary muscle rupture is a life-threatening complication due to surrounding tissue necrosis. This causes a severe acute mitral regurgitation, and that leads to hypotension and pulmonary edema. Dressler syndrome can occur weeks after an MI, and then how do you treat Dressler syndrome is with NSAIDs. Those are the mainstay of therapy, as well as corticosteroids can be used in refractory cases when NSAIDs are contraindicated or if NSAIDs didn't work. So anticoagulants should be avoided in Dressler syndrome to prevent developments of hemorrhagic pericardial effusion. So how would you manage an ST wave elevation MI or a STEMI? So first of all, you see the initial stabilization of an acute ST elevation MI. You want to give them supplemental oxygen if the SaO2 is going to be less than 90%, or if they have dyspnea, you have to give them aspirin, a P2Y12 inhibitor like clopidogrel. Remember, clopidogrel is P2Y12 inhibitor. They like to interchange that on the exam. Sublingual nitrogen, beta blockers, unless they're hypotensive, obviously, or if they're bradycardic, or if they have chronic heart failure or a heart block, you want to give them a beta blocker. High dose statins as well, like atorvastatin, that's 80 milligrams. And anticoagulation, the drug is going to depend on the planned revascularization. So you give them all those: anticoagulation, high dose statins, beta blockers, nitrates, clopidogrel, aspirin, and supplemental oxygen first. Now, you want to see if they have persistent pain, if they have severe pain, unstable pain, pulmonary edema. So let's go one by one. So let's say if you give them all those and they still have persistent pain as well as hypertension or heart failure, then you want to give them IV nitroglycerin, but not if they have hypotension or right ventricular infarctions or severe aortic stenosis. If they have persistent severe pain alone, then you can just give them IV morphine. If they have unstable sinus bradycardia, you can give them IV atropine. And then if they have pulmonary edema, obviously loop diuretic like furosemide, but you don't want to give that if the patient's hypotensive or hypovolemic for obvious reasons. All of those cases, in all those cases, this is going to lead to reperfusion, a percutaneous transluminal coronary angioplasty, or a PTCA, within 90 minutes is going to be the preferred choice, as well as thrombolysis if that PTCA is not available within 120 minutes or 2 hours. So beta blockers should not be used in cases of pulmonary edema. Examples would be in like an acute decompensation. Morphine is going to be an anxiolytic, so that's going to decrease preload, and it should not be routinely used because there's a increased risk of mortality, as well as ischemic heart failure that's secondary to MI. that can lead to an acute pulmonary edema and a flash pulmonary edema. Stent thrombosis is going to be a potentially fatal complication of coronary artery stenting and long-term dual antiplatelet therapy with aspirin and platelet receptor blockers like your PT-Y12, which is the clopidogrel that we were saying. Clopidogrel is recommended to reduce the complications of stent thrombosis. So if you ever see a question in the vignette that says that this patient just underwent stenting and you want to know what management should you give this patient at home, and it would be to give them clopidogrel, discharge them with clopidogrel afterwards. So premature discontinuation of these medications is going to be the strongest predictor of stent thrombosis, and there's within the first 12 months. So screening and counseling regarding medicine compliance is going to be needed. All right, so some of the managements of ST segment elevation MIs are going to be, like we said, you want to give them oxygen for arterial saturation. You can give them nitrates, but be careful again if they're hypotensive. Or if they have a right ventricular infarction or severe aortic stenosis, be careful with that. Antiplatelet therapy, again, with aspirin and P2Y12 receptor blockers like clopidogrel. Anticoagulation with unfractionated heparin, low molecular weight heparin, or bivalirudin. You can give them beta blockers, but it's contraindicated in overt heart failure. There's a high risk of cardiogenic shock, and it can also cause bradycardia. Also, prompt reperfusion of a PCI is going to be ideal. First medical contact with the PCI is less than 90 minutes. So you want to do that within 90 minutes of PCI, percutaneous coronary intervention. And then statin therapies are going to be given as soon as possible. So remember, oxygen, nitrates, clopidogrel, aspirin, anticoagulation with heparin, beta blockers, reperfusions with a PCI within 90 minutes, and statin therapies. Those are all the managements of ST wave segment elevation MIs. Aspirin in full doses is given to be chewed for a quick action. So if you want something quick, you can chew aspirin at full dose. Morphine can also be given for pain control if nitroglycerin is insufficient. Nitroglycerin mainly causes dilation of the capacitance vessels or the veins. So that's a very common test question. What is the mechanism of nitroglycerin? Or won't say it that way. They'll just give you the scenario where you need to give them nitroglycerin to resolve an acute angina. And then they'll ask you, what is the mechanism of action of the medication that you would most likely start them on? And it's dilation of the capacitance vessels or the veins. That's going to decrease preload. You don't want any more blood in the heart so that the heart works more. So it decreases preload. And by decreasing preload, you decrease the size of the heart. And by doing that, you decrease the oxygen demand. And it also dilates the arteries, and it decreases afterload, but that's not going to be significant. It's not used to decrease afterload, even though it does. It's mainly to decrease preload. So nitroglycerin, the mechanism of action is to decrease preload to ultimately decrease oxygen demand in the heart. Next would be prompt coronary reperfusion with a PCI or fibrinolytic therapy. That's going to restore the blood flow as well as limiting myocardial oxygen damage, and it also reduces mortality, which is the most important intervention to improve long-term prognosis. Current guidelines for a PCI for patients with an acute ST wave elevation MI is within 12 hours of symptom onset and within 90 minutes from first medical contact to device time at the PCI capable facility. So within 90 minutes is the best one. Within 120 minutes from first medical contact to the device time at a non-PCI capable facility, and that's used to allow time for transport to a PCI capable facility. So a PCI has a better survival and less risk of an MI and stroke as compared to fibrinolytic therapy, which can be done if within 12 hours of symptom onset, who cannot undergo a PCI. A PCI isn't available within the recommended time frame, you can give them fibrinolytic therapy. If fibrinolytics are being used, then door to needle time should ideally be between 30 minutes. So very quick. Management of non-STEMIs would be revascularization with drug-eluting stent placement. So if you have a non-ST wave segment MI, revascularization with drug-eluting stent replacement is number one, as well as long-term therapy for secondary prevention. So that long-term therapy would be like dual antiplatelet therapy with aspirin and the P2Y12 receptor blockers like clopidogrel, prasugrel, ticagrelor, and these are going to significantly reduce a recurrence of an MI as well as cardiovascular death compared to just aspirin alone. Long-term dual antiplatelet therapy is going to reduce stent thrombosis, and it's recommended for at least a year in all the patients following drug-eluting stents. On other types of long-term therapies would be beta blockers, ACE inhibitors, ARBs, statins, and aldosterone blockers if the ejection fraction is less than 40% with heart failure symptoms or if they have diabetes mellitus. And remember that ACE inhibitors should be started in all patients with MIs within 24 hours to prevent remodeling of the heart. So that's another huge question that they love to ask. ACE inhibitors are given to prevent remodeling. So an example of that would be a dilation of the left ventricle with thinning of the ventricular wall, which takes weeks to months. You don't want that wall to be too thin because you'll be at risk for rupture. So apixaban is a factor 10A inhibitor, and that's used for anticoagulation in non-valvular atrial fibrillation for the management of DVT and pulmonary embolism. So the next topic is causes of heart failure with preserved left ventricular function, or diastolic dysfunction in other words. So diastolic dysfunction, another way of saying is heart failure with preserved left ventricular function. Common causes of decompensated congestive heart failure signs with normal or near normal ejection fractions, so more than 50% ejection fraction, that's exacerbated by loss of the atrial kick. So what are some causes of heart failure with preserved left ventricular function? So diastolic heart failure will be caused by hypertension with left ventricular hypertrophy. Restrictive cardiomyopathy can also cause a diastolic heart failure. Infiltrative cardiomyopathies like sarcoidosis, hypertrophic cardiomyopathies, as well as occult coronary artery disease can all cause diastolic heart failure. For valvular heart disease, the most common ones would be aortic stenosis or aortic regurgitation and mitral stenosis or mitral regurgitation. For pericardial diseases, there's constrictive pericarditis and cardiac tamponade. Those are going to be causes of the heart failure with preserved left ventricular function. And then finally, for systemic disorders like high output cardiac conditions, this would be like your thyrotoxicosis or severe anemias. All of those can cause heart failure with preserved left ventricular function. So what are some of the hemodynamics in heart failure? So let's start off by seeing a heart that has low contractility. That decrease in contractility is going to cause a decrease in cardiac output. If the heart can't contract, it can't let out anything. So decrease in cardiac output. This is going to cause a compensatory neurohormonal activation, which is going to then increase systemic vascular resistance to compensate. So if you're not pumping out any blood, your systemic vasculature is going to constrict to increase vascular resistance. Because of this, though, you'll have an increase in backflow to the heart, causing an increase in afterload. And it's just a downward spiral. More afterload means it's harder to contract, decrease in cardiac output, compensatory systemic vascular resistance, more afterload, and so on and so on. So it's pretty bad. So acute decompensated heart failure, clinically, they present with acute dyspnea, orthopnea, paroxysmal nocturnal dyspnea, hypertension is common, as well as hypotension, but that suggests severe disease if they're hypotensive. Accessory muscle use, tachycardia, tachypnea. They can have diffuse crackles with possible wheezes, and cardiac asthma. That's called cardiac asthma, when you have crackles and wheezing with heart failure. There's also a possibility of having an S3, a jugular venous distension, as well as peripheral edema. So how would you treat acute decompensated heart failure? So if there's normal or elevated blood pressure with adequate end organ perfusion, you want to give them supplemental oxygen, IV loop diuretics like furosemide to let go of some of that liquid. And you also want to consider IV vasodilators like nitroglycerin, which, remember, decreases preload. All right. Also, you want to treat hypotension or signs of shock, again, with oxygen, loop diuretics, and vasopressors like norepinephrine. The most common causes would be left ventricular systolic or diastolic dysfunction with or without additional cardiac defects, such as an acute MI, arrhythmia, or acute severe mitral regurg, or an aortic regurg. In pulmonary edema, that can also occur with severe hypertension. So severe hypertension can lead to a pulmonary edema, also renal artery stenosis, or severe renal disease, and that's due to the fluid overload. Nitroglycerin is going to be really beneficial to these patients with mitral regurgitation or with symptomatic myocardial ischemia, and because, again, you're decreasing preload, which decreases oxygen consumption of the heart. Then you have your cardioselective beta blockers, but these are contraindicated in acute settings. So an elevated BNP with an S3 gallop, those are going to correlate with an increased cardiac filling pressure, and it's noted in patients with CHF due to left ventricular systolic dysfunction. So if you ever see a BNP or S3, you're thinking CHF or systolic dysfunction. A pro-BNP produces active BNP and an N-terminal pro-BNP. Both of them are going to correlate with the severity of left ventricular systolic dysfunction. Remember that BNP has a very high negative predictive value, and if a negative test results, you would need to look for other causes. Peripheral edema also does not correlate with a BNP as much as an S3 does. So what are some of the poor prognostic factors in systolic heart failure? So you'll have a poor prognostic factors would be clinically, they'll have higher New York Heart Association functional class. There'll be a resting tachycardia, presence of an S3 gallop, an elevated jugular venous pressure. There's low blood pressure, which is a blood pressure that's less than 100/60, moderate to severe mitral regurgitation, and as well as low maximal oxygen consumption. On labs for systolic heart failure, there could be hyponatremia because of that high fluid overload. There can also be elevated pro-BNP levels as well as renal insufficiency. On EKG, the QRS is going to be widened at more than 120 milliseconds. So there's a widened QRS complex, left bundle branch block pattern. And on echocardiography, there's going to be severe left ventricular dysfunction with a concomitant diastolic dysfunction and reduced right ventricular function, as well as pulmonary hypertension because of that backup. Remember, this is just fluid overload. And its associated conditions are going to be anemia can cause it, atrial fibrillation can cause it, as well as diabetes mellitus. So hypernatremia or hyponatremia in patients with congestive heart failure is usually parallel to the severity of the heart failure, and it's independent predictor of adverse clinical outcomes. There's going to be a decrease in perfusion at the pressure at the baroreceptors and the renal afferent arterioles. The decrease in pressure in the renal afferent arterioles is going to cause a neurohormonal activation of renin, norepinephrine, and antidiuretic hormone secretion. That antidiuretic hormone is going to promote free water absorption. It's going to promote renin and norepinephrine, and it's going to increase proximal sodium and water absorption, as well as limiting water delivery to that distal tubule. That is then going to cause a free water retention and a dilutional hyponatremia. So it's basically the more water you're holding in, the more dilute your sodium will be, and electrolytes as well as increases in antidiuretic hormone. So that's about all you have to know. Also, restrict water intake. You want to restrict ACE inhibitors and loop diuretics. Initial therapy in hyponatremia in congestive heart failure patients is to give them salt tablets. It can be given in SIADH, but not in states of edema. So next topic, moving on, is how would cocaine induce an ST wave elevation MI? So clinical features would be sympathetic hyperactivity like tachycardia, hypertension, dilated pupils. There can be chest pain due to coronary vasoconstriction, as well as psychomotor agitation and seizures. Complications of cocaine use can give you an acute MI. It also can give you aortic dissection and intracranial hemorrhaging. And the management of chest pain with cocaine use is, number one, is to give them a benzodiazepine for blood pressure and anxiety. That is a highly tested topic, and it's very commonly asked. So patient comes in, cocaine use, and they're having an MI or chest pain. What do you give them? Benzodiazepines. You can also give them aspirin, nitroglycerin, and calcium channel blockers for pain. Beta blockers, again, are contraindicated. Fibrinolytics are not preferred due to the increased risk of intracranial hemorrhaging. And immediate cardiac catheterization with reperfusion is only done when indicated. It's associated with pupillary dilation and blood-crusted noses. So you'll see some blood in the in the nares, as well as mydriasis. Cocaine is also enhances thrombus formation by enhancing platelet activation and aggregation. So when you're taking cocaine, it actually increases how your platelets work and activate. So there can be an increased risk of thrombus formations. Benzodiazepines, which are the treatment that you give them, that's going to decrease myocardial oxygen demand, and it's going to alleviate cardiovascular symptoms as well. And it's given in IV form with supplemental oxygen, and as well as alpha blockers like phentolamine can also help reduce the vasospasms. So aortic valve endocarditis and AV block is the next topic. So when aortic regurg is due to the aortic regurg is due to a valvular disease, the murmur is heard along the left sternal border, usually within the third and fourth intercostal space. When aortic regurg is consisting of an aortic root dilation, then the murmur is best heard at the right sternal border. If there's a new AV block present in cases of an IV drug user, along with an aortic regurg murmur, you want to suspect perivalvular abscesses extending into adjacent cardiac conduction pathways. So you'll have conduction deficits, but those aren't common in tricuspid endocarditis. So remember IV drug users in this case. And this occurs in 30 to 40% of patients with infective endocarditis. And aside from aortic valve replacement, IV drug users are also independent predictors of periannular extensions of infection. All right, so hypertrophic cardiomyopathy is the next topic. So what are some of the effect of maneuvers on hypertrophic cardiomyopathy? So Valsalva and straining, abrupt standing, so basically from a sitting or a supine position, you just stand up really quick, and giving them nitroglycerin. All these are going to decrease preload. And how is this going to affect the murmur? It's going to increase the intensity of the murmur. A sustained hand grip, that's going to increase afterload. A squatting is going to also increase afterload, and it's also going to increase preload as well. And then passive leg raising is going to increase preload. The way I see it, if you raise your leg, you're draining blood from your legs back into your heart, increasing preload. So that's a good way of seeing that. Hypertrophic cardiomyopathy is very common in African American populations, and that is due to an autosomal dominant condition. Two most common mutations responsible for about 70% of cases. Number one are cardiac myosin binding protein, C gene, and you have your cardiac beta myosin heavy chain gene. And patients may be asymptomatic or present with dyspnea on exertion or chest pain, palpitations, pre-syncope or syncope, and up to half of the patients are going to die suddenly of HOCM or hypertrophic cardiomyopathy don't have any prior symptoms. Myocardial hypertrophy and fibrosis is going to peak during puberty, and exertion can precipitate an acute left ventricular outflow tract obstruction or a ventricular fibrillation. So what's happening here is that their septum is kind of hypertrophied. And because of that, it's impeding on that valve. So because of that, blood cannot exit the heart. So that leads to a left ventricular outflow tract obstruction. So hypertrophic cardiomyopathy with significant left ventricular outflow tract obstruction causes systolic ejection murmurs along the left sternal border with a strong apical impulse. And all athletes are going to need to undergo a pre-participation evaluation before being cleared for any sport, because this is preventable. This usually happens in a young athlete playing football or whatever, and suddenly they just collapse and die. So this is completely preventable as long as you don't overstrain yourself. Family history of sudden unexplained death should also prompt you to get an echo and an EKG, and patients should refrain from exertional thrills, and if nothing is found on these tests, as well as athletes without prior cardiac conditions can develop fatal ventricular fibrillation after suddenly having blunt chest trauma, and that's known as commotio cordis. So other causes of sudden cardiac death would be coronary artery disease, cardiomyopathies like hypertrophic cardiomyopathy, like we just said, arrhythmias like long QT syndrome, and congenital heart defects. So in a hypertrophic cardiomyopathy, you'll have left ventricular hypertrophy, which means you'll have a tall R wave in AVL with a deep S wave in V3, and that's your Cornell's criteria, as well as repolarization changes in the anterior lateral leads. So those would be repolarization in leads 1, AVL, V4, V5, and V6. So remember the tall R wave in AVL and a deep S wave in V3. That's a good one to remember. All right, next topic would be restrictive cardiomyopathy. And this is less common than dilated cardiomyopathies, and it's less common than HOCM. It's caused by an infiltrative disease like sarcoidosis and amyloidosis, and as well as storage diseases such as hemochromatosis and endocardial fibrosis, as well as it can be idiopathic. So hemochromatosis is going to be the only one which is actually reversible with treatment. So that would be like phlebotomy. So the primary causes of diastolic dysfunction with minimally affected systolic function is restrictive cardiomyopathy. So that's a diastolic dysfunction. And the left ventricular volume is normal, as well as the wall thickness. And that could be also normal, or it could be symmetrically thickened. And that's distinguished from HOCM, where the intraventricular wall is thick. So, or the septal wall is thick. But in here, in restrictive cardiomyopathy, it could be normal. Right heart failure signs are going to be prominent, but it can also cause signs of left heart failure. So amyloidosis, that would be one of the restrictive cardiomyopathies. It's an extracellular deposition of insoluble polymeric protein fibrils in the tissues and in the organs. So that protein gets deposited into the muscle fibers of organs. And it can be primary the AL type of amyloidosis or secondary AA type to chronic inflammation, chronic inflammatory conditions such as inflammatory arthritis, which is a rheumatoid arthritis would be an example of that. Chronic infections like bronchiectasis, tuberculosis, or osteomyelitis. Inflammatory bowel diseases like Crohn's diseases, and malignancies such as lymphoma, as well as vasculitis can lead to amyloidosis. So typically it's going to be inflammatory conditions that are chronic can lead to amyloidosis. So clinical presentation can be asymptomatic. So they can have asymptomatic proteinuria or nephrotic syndrome. They can have a restrictive cardiomyopathy in presentation, hepatomegaly, peripheral neuropathy or autonomic neuropathy, visible organ enlargement like a macroglossia, and bleeding diatheses. They can have waxy thickening and easy bruising of the skin. So the skin could look waxy or thick, and it could be easily bruised. Diagnosis is with an abdominal fat pad aspiration biopsy. So if they ask you how do you diagnose it, it's with a fat pad aspiration biopsy. Predominantly, it's a diastolic dysfunction, and patients can develop syncope or pre-syncope due to the conduction abnormalities. On EKG, there'll be a low voltage, and on echo, they'll have an increase in ventricular wall thickness with a normal ventricular cavitary dimensions, and that's especially without hypertension. Tissue biopsy is going to be like an abdominal fat pad biopsy, like we said, bone marrow biopsy, rectal biopsy, kidney biopsy, endomyocardial biopsies, and these can all confirm the diagnosis, showing amyloid depositions. Sarcoidosis is another restrictive cardiomyopathy that can cause a granulomatous infiltration of the myocardium and heart failure with both systolic and or diastolic dysfunction. And sarcoidosis is going to affect young adults, and that's going to involve the lungs, the skin, and the eye. Okay, so that was restrictive cardiomyopathies. We're moving on to dilated cardiomyopathies. As a result of toxic alcohol, it could be metabolic, like in hemochromatosis, or infectious agents. There could be viral myocarditis with a history of recent upper respiratory tract infection. So they'll say that in a vignette. They'll say this patient comes in, he recently recovered from a viral infection 2 weeks ago or a week ago, and so on and so forth. And that would be a viral myocarditis. The most common cause of dilated cardiomyopathy is going to be a Coxsackie B virus. Other causes could be your parvovirus B19. It could be HHV6, adenoviruses, and enteroviruses. And the mechanism of action is that it's going to be a direct viral damage, and as a result of humoral or cellular responses to persistent viral infections. Diagnosis is going to be made with an echo that's going to show dilated ventricles with diffuse hypokinesia, and that's going to result in a low ejection fraction, like in a systolic dysfunction. And treat is largely supportive, mainly the management of CHF symptoms. All right, next topic is cardiac tamponade. In cardiac tamponade, this can be compared to dilated cardiomyopathy. So in tamponade, there will be a clear lung field, versus in dilated cardiomyopathy, they'll have bibasilar crackles, and that could be heard with pulmonary venous congestion, and it could be seen on X-ray with fluid building up. So an S3 will be heard in a dilated cardiomyopathy. Cardiac tamponade can be idiopathic, and it's usually viral, and it can be bacterial, fungal, or neoplastic, and it's primary, or it could be metastatic. It could be found post-MI, like we've said before, due to traumas. Uremia can do it, autoimmune diseases, and hypothyroidism. There'll be an enlarged globular-looking cardiac silhouette that's water bottle-shaped heart. That's like the main one that they describe it as. Mainly it affects the right side of the heart with an inability to palpate the point of maximal impulse. There's a beat-to-beat variations in the QRS complexes and the axes with electrical alternans. Electrical alternans is going to be very specific for this diagnosis. And that electrical alternans can be with a sinus tachycardia, and that's highly specific for a pericardial effusion. And if you see that will require an emergency pericardial centesis. So what is electrical alternans? And electrical alternans, simply put, is alterations and alternating amplitudes or voltages, alternating voltages of the QRS complex. So some of them are going to be smaller than the other one, and it'll go small to longer, small, longer, and that alternation is called electrical alternans, and that's specific to the cardiac tamponade because it's kind of like the heart swinging inside the pericardial cavity. The closer it gets to the anterior portion, the higher the amplitude or the voltage. The further away it gets, the smaller the voltage, so it's kind of like swinging like a bell. And that's why you get the electrical alternans. And that's seen throughout the QRS complex. So I like to just see it on leads 2 or V6 or whatever, but it'll be there. It'll be very obvious. So what are some auscultation cardiac murmurs? So what are the maneuvers? What is it going to do? The murmurs when it gets louder, when it gets softer, what's going to happen? So in a Valsalva maneuver, so we're going to talk about Valsalva maneuver, standing, squatting, hand grip. So in a Valsalva, what it does is that early on there's a strain, and that's going to decrease venous return. It's also going to decrease all the murmurs except for HOCM and mitral valve prolapse because it decreases venous return. And it's also going to be, and then late findings would be a release, and that would be an increase in venous return and an increase in right-sided murmurs. Now, murmurs that get louder with Valsalva would be your HOCM and your mitral valve prolapse. With HOCM, it's going to have a decrease in left ventricular volume, causing an increase in gradient. And in mitral valve prolapse, the decrease in left ventricular volume causes an increase in leaflet prolapse. So what they're saying there is that because there's less blood in the heart, these murmurs are going to be louder because since there's no blood in there, then mitral valve prolapse, there won't be that blood pushing up against the the valve to hold it shut. So since there isn't that happening, then that valve is going to be loosely flopping. With HOCM, you won't have that blood pushing up against that septum, letting blood flow through the outlet. So in this case, since there's no blood or little blood, then that hypertrophy in the septum is going to cause the valve to close harder. And then murmurs that get softer. So all other murmurs are going to get softer. Remember, there's a mnemonic that says more blood, more murmur. So in this case, when you Valsalva, since you have a decrease in venous return, you have less blood, which means you have less murmur. And all the other ones except for HOCM and mitral valve prolapse are going to be decreased. So because of the decrease in flow through that stenotic or regurgitant valve during the strain phase, that's the Valsalva. Next is going to be standing. So when you're standing, there's decreased venous return to the heart. It's similar to Valsalva in the sense that blood's not getting into the heart. It's kind of pooling in the lower extremity. So there's decreased venous return, and it's similar to the strain phase of the Valsalva, like we just said. And because of that, exact same thing happens with the murmurs. As the murmurs, the only murmurs that get louder are going to be HOCM and mitral valve prolapse, and all the other murmurs are going to be decreased because of the stenotic or regurgitant valve during the strain phase. When you're squatting, however, you're going to increase venous return. Also, there's going to be an increase in afterload by kinking of the femoral arteries. So when you press up against the femoral arteries, afterload increases because the blood can't go all the way to its destination, so it backs up into the heart, increasing afterload. But it also, since you are squatting, that pressure goes back into the heart and it fills up the heart, so venous return will be increased. However, afterload will also be increased. And there's an increase in reverse flow. So which ones are going to get louder? It's going to be the opposite, right? So here you'll have more blood in the heart, so aortic regurg, mitral regurg, VSDs, all those flow murmurs are going to be increased, and your HOCM and your mitral valve prolapse are going to be softer. Hand grip is also going to increase in afterload. It's going to increase blood pressure, and there's also going to be an increase in reverse flow across the valve. So again, hand grip is going to cause more blood inside the heart because of the increase in afterload. And because of that, the same murmurs are going to be louder. Aortic regurg, mitral regurg, VSDs. And the ones that are going to get softer are your HOCM, but also aortic stenosis is going to be decreased. So aortic stenosis because of a decrease in transvalvular pressure gradients. All right. So what are some of the gallop heart sounds? So a gallop heart sounds could be an S3 or an S4, and that an S3 is your third heart sound, and it's a ventricular gallop, and it's heard after an S2. It's heard during rapid filling of the ventricles and diastole, and it causes turbulent blood flow to the ventricles due to an increase in volume. It's normal in children, it's normal in the young population, so young adults, and it's also normal in pregnancy. These are all states where you have normally more volume. So abnormal associations would be if this is happening when you're greater than 40 years of age, or if there's heart failure, or if there's a restrictive cardiomyopathy or high output states. An S4 is your fourth heart sound. And this is an atrial gallop that happens before S1. So the third happens after S2, so that's not that hard to remember. S1, S2, S3. But then S4 happens before S1. So the pattern here is S4, S1, S2, S3. So it's heard immediately after an atrial contraction phase as the blood is then forced into a stiff ventricle. That's the mechanism of why you hear it. Here, the gallop heart sounds are normal in healthy patients that are older. adults. So then if it's normal in the elderly or in the older population, then it's abnormal in young adults, and it's also abnormal in children. It's abnormal in ventricular hypertrophy, or it's associated with ventricular hypertrophy, and it's also associated with an acute MI. So an S4 is heard in an acute MI because of ischemia that is inducing a myocardial dysfunction. So the ischemia causes a myocardial dysfunction, and that's going to be heard in the setting of an acute MI. Okay, so what are some of the benign versus the pathological murmurs? So which ones are benign, which are pathological? So benign murmurs are going to be like normal appetite, energy, activities, and growth. That's your history, and no significant family history. So if a patient comes in with normal appetite, normal energy, normal activity, normal growth, and nobody in the family has any type of murmur, then that's usually benign. The features of that murmur to be benign is that it has to be either early or mid-systolic. A grade 1 or 2 intensity is also benign, that decreases on standing and on Valsalva maneuver, as well as low-pitched musical murmurs. Never heard of that, but musical murmurs, and pure or squeaky tones at the left lower sternal border. And also you have that's also called a Stills murmur. That's your squeaky murmur, or a high pitched at the lower and upper sternal border. And that's a pulmonary blood flow murmur. Other findings, there is no other findings, and there's no workup needed. So if you see any of those, that's benign. You don't have to worry about it. They try to trip you up on some of these questions, and they'll say he has a grade 2 systolic murmur, or he has a grade 1 mid-systolic murmur. So, I mean, it sounds like there's something wrong there, but no, grade 1 and grade 2 are absolutely normal. So don't worry about any type of murmur pathology on the answer choices if that's what you're given. Now, however, if it's pathological, they'll come in with diaphoresis and fatigue, with feeding and exercise intolerance, also poor weight gain, chest pain, dizziness, syncope, shortness of breath. First of all those signs are abnormal to begin with, so you're already thinking something's wrong. Also, a positive family history of sudden cardiac death, heart defects, etc. You kind of get the picture. That's a worse prognosis. That's a bleaker picture. So here you're thinking more pathological. The features of pathological murmurs would be harsh, hollow systolic, diastolic murmurs. Diastolic murmurs are never good. Grade 3 or higher, and that it increases with standing and increases with Valsalva maneuver. Other findings with pathological murmurs are that they're loud. Also, if they're fixed or split, or if they have a single S2, as well as decrease or absent femoral pulses. Again, absent femoral pulses or decreased femoral pulses is not good to begin with either, if you think about it. So that's pathological. Workup would be to do an EKG to assess for hypertrophy, or an echocardiogram to assess for structural abnormalities, as well as referral to cardiology. But again, referral is hardly ever the answer choice on the exam. The key here to distinguishing features of benign versus pathological murmurs is going to be the changes in intensity with the changes in position. Position that decreases venous return to the heart decreases the intensity of an innocent murmur. So the management here would be reassurance and observation if the murmur is benign. Next one is hepatojugular reflux, and that's used to differentiate between cardiac and liver diseases. So elevations of jugular venous pressure is going to be more than 3 centimeters during like an abdominal compression, and that would be signs of a failing right heart. It's common in constrictive pericarditis and a right ventricular infarction, as well as a restrictive cardiomyopathy. All those are going to give you hepatojugular reflux: constrictive pericarditis, right ventricular infarctions, and restrictive cardiomyopathy. Now, constrictive pericarditis, the major causes of constrictive pericarditis are going to be right heart failures. There can be hepatic congestion with hepatomegaly and eventual progression to cirrhosis, and that would be called cardiac cirrhosis. There's an increase in jugular venous pressure as well with a hepatojugular reflux. So you press up against the liver and suddenly you have your increase in JVP. Also, they have Kussmaul signs, which is a lack or a decrease of an increase in jugular venous pressure on inspiration. So when you take a breath in and you suddenly see the jugular venous pressures going up, that's your Kussmaul sign, and that's constrictive pericarditis, as well as pericardial knocks and pericardial calcifications seen on chest x-ray. So what are some of the features of constrictive pericarditis? So the etiology here is that it could either be idiopathic, so you don't know, or a viral pericarditis can cause a constrictive pericarditis. Also, cardiac surgeries or radiation therapy can irritate that cardiac muscle, causing a constrictive pericarditis, as well as tuberculous pericarditis than tuberculosis endemic areas. So clinically, how do they present? With fatigue and dyspnea on exertion. They can get peripheral edema and ascites. They can have increase in jugular venous pressures. A pericardial knock can be heard. So if you ever hear pericardial knock, you're thinking of a constrictive pericarditis. Pulsus paradoxus and that Kussmaul sign. And some of the diagnostic findings would be on EKG. That can be nonspecific, or it can actually show atrial fibrillation or a low voltage QRS complex. Because of that really thick pericardium, it's kind of hard to get any kind of electrical readings through that EKG, so your QRS complexes are going to be very small. Images are going to show pericardial thickening and calcifications, and there will be a jugular venous pulse tracing that shows prominent X and Y descents. So yeah, that's your JV pulse tracings, X and Y descents. Echo is going to confirm the diagnosis, and that's going to show an increase in pericardial thickness with an abnormal septal motion and bilateral enlargement. How you treat is with diuretics. Diuretics are going to cause temporary relief, and then the definitive treatment is going to be pericardiectomy if it's refractory to diuretics. And so that's how you treat it. Survivors of Hodgkin's lymphoma can present as much as 10 to 20 years after a mediastinal irradiation or anthracycline therapy. So kind of remember that. There has been a test question where it shows Hodgkin's lymphoma, and then suddenly they'll have pericarditis. Why? And it's because of the anthracycline therapy or radiation that they did previously. Cardiac complications of Hodgkin's lymphoma are going to be either acute or delayed pericardial diseases. There could be myocardial ischemia and infarction because of that, and restrictive cardiomyopathies, CHF, valvular abnormalities, and also conduction defects. Moving on, we have pericarditis. So some of the etiologies of pericarditis can be either infectious pericarditis, iatrogenic pericarditis, connective tissue diseases, cardiac causes specifically causing pericarditis, uremic causes, and malignancy. So an infection, viral is going to be the most common, followed by bacterial. Iatrogenic would be like through surgery or trauma or radiation exposure or drug related. That's all iatrogenic causes of pericarditis. Connective tissue diseases like rheumatoid arthritis and lupus can cause a pericarditis. cardiac causes of pericarditis would be like Dressler syndrome, and that's a post-myocardial pericarditis, and that's usually 1 to 6 weeks after an MI. There's uremic pericarditis, which has an increase in BUN. That's usually more than 60 milligrams per deciliter of uremia. But the degree of the pericarditis isn't always correlating with the degree of the elevation. And as well as malignancy, because it can be due to cancer like lung and breast cancer, Hodgkin's lymphoma, or radiation or chemotherapy. So treatment for the malignancy can cause pericarditis, versus radiation alone, that would be an iatrogenic cause. All right, so uremic pericarditis, this occurs in 1 to 6% of patients with renal failure. So that's another thing you have to worry about with renal failure patients is uremic pericarditis. It involves visceral and parietal membranes of the pericardium, and it does not present with the classic EKG findings of pericarditis because the inflammatory cells don't penetrate the myocardium, and then there's lack of involvement of the epicardium. Here, dialysis is going to be the most effective treatment for uremic pericarditis, and it can resolve the symptoms and decrease the size of any kind of pericardial effusion. Also, NSAIDs and colchicines are good first lines for idiopathic or acute viral pericarditis, but in uremic pericarditis, it's only used if the patient isn't responding to dialysis. So be careful with that, because you would think that NSAIDs maybe could be beneficial since it's less it's less invasive or less intensive procedure than dialysis. But in uremic pericarditis, since it's due to renal failure, dialysis would be number one. And if that doesn't work, then you get the NSAIDs or the colchicine. And you also want to avoid anticoagulants because that can lead to hemorrhage into the pericardial sac. And an acute pericarditis, that can cause diffuse ST segment elevations on the EKG, and that's accompanied by PR depressions in the limbs and the left precordial leads. So what are some of the indications for urgent dialysis, since we're on the topic of dialysis? And here there's a mnemonic called AEIOU, so all your vowels for urgent dialysis. So A for acidosis, so you have a metabolic acidosis, so a pH that's less than 7.1, that's refractory to medical therapy. Medical therapy doesn't work to help that pH. You have metabolic acidosis, then that's a good indication for dialysis. The E is for electrolyte abnormalities. That could be either symptomatic hyperkalemia or EKG changes or ventricular arrhythmias, as well as severe hyperkalemia, so like a potassium that's more than 6.5, again, that's refractory to medical therapy. Then you do urgent dialysis. The I is for ingestion of what? Of toxic alcohols like methanol, ethylene glycol, salicylates, lithium, sodium valproate, and carbamazepine. The O is for fluid overload, that's refractory to diuretics. So you can't just give somebody dialysis because they're volume overloaded. You have to first give them diuretics. If that doesn't work, then the urgent dialysis is needed. And then finally, the U is for uremia, and this is symptomatic uremia, obviously, leading to encephalopathy, pericarditis, or uremia that leads to bleeding. All right, moving on, we have heart block. Heart block can be first degree heart block, second degree type 1, type 2, and type 3. So first degree AV block, this is due to a delayed impulse transmission from the atria to the ventricles at a number of possible locations, including the atria, the AV node, the bundle of His, or the something called the infrahysian conduction system, or which are the bundle branches, or the fascicles. And this is going to lead to a prolonged PR interval that's going to be greater than 0.20 seconds. So if you see PR intervals greater than 0.20 seconds, this is a AV block. PR intervals are going to remain constant in first degree. Most first degree AV blocks with normal QRSs are due to conduction delays in the AV node, and that leads to you not having to further evaluate anything, because first degree AV blocks are benign, but they are associated with high risks of heart failure. They can lead to atrial fibrillations and overall mortality. So even though they are benign, watch out, because it could be a telltale sign for something else later on. First degree AV blocks with wide QRS complexes, more than 120 milliseconds, as well as conduction delays below the AV node, mostly at the bundle branches, can have unpredictable progressions to second and even third degree AV block, and they should get electrophysiological testing to determine the site of the conduction delay. Some patients with first degree AV block with marked prolongation of the PR interval can develop pacemaker-like symptoms, and that would lead to uncomfortable sensations of awareness of heartbeats due to atrial contractions against closed mitral valves during a ventricular systole. Such symptomatic patients are potential candidates for pacemaker explanations. Okay, so first degree heart block, we said that the PR interval is going to be greater than 0.20 milliseconds, which is about the size of about 5 small little boxes. So if it's greater than 5 small little boxes and it's happening continuously, that's a first degree AV block. Now, second degree AV block can be divided into Mobitz type 1, type 2. So a Mobitz type 1, the level of the block is usually going to be the AV node. On EKG, there's going to be a progressive prolongation of the PR interval that leads to a non-conductive P wave. So you have grouped beatings. And the QRS complex is going to be narrow. If you give atropine, atropine is going to improve type 1 AV blocks. Vagal maneuvers are going to worsen type 1 AV blocks, like carotid massage. And there's a low risk for heart block in these patients, of complete heart block. There's already a heart block, but a complete heart block in type 1, there's low risk. Now, type 2 heart blocks, AV block, second degree AV block type 2, is below the level of the AV node, and that's usually found at the bundle of His. The PR interval is going to remain constant with intermittent non-conductive P waves. The QRS complexes are either going to be narrow or wide, so you really can't determine it that way. But if you see a wide QRS complex, maybe it's a second degree type 2. And atropine here is going to worsen a type 2 AV block, versus in type 1, atropine improves an AV block. So in type 2, in second degree type 2, atropine worsens the AV block. Vagal maneuvers are going to actually improve a type 2 AV block, versus in a type 1, they worsen it. And there is a higher risk for heart block in second degree AV block type 2, and it might require an indication for a pacemaker. So again, a Mobitz type 1 is usually due to a delay of the break in the cardiac electrical signal pathway from the atria to the ventricles. This can occur in healthy people, it can occur in athletes, and in older patients, and people with heart diseases, and those who are on drugs that can block the AV node. What are some of the drugs that can block the AV node? Digoxin, beta blockers, calcium channel blockers. And in a Mobitz type 1, what you need to remember is that the P to P interval is going to be constant. The PR interval is going to be increasing. And there's going to be a decreasing in the R to R intervals. There can be predictable grouping between the P and the QRS complexes before the dropped QRS complex happens. So an example of that would be like for every 3 P to QRS complexes, there's going to be a drop, and this is called a group beating. I kind of don't like that term, but that's what it's called, a group beating. But the way you remember this is that little song and dance, longer drop. Then you have a Winky Bach. A Winky Bach is a Mobitz type 1. which is a second-degree AV block. And the treatment here is to observe in asymptomatic patients, as it's just only a benign condition, especially young patients with good ventricular function, with correctable causes, like if they're able to be corrected with medications, that's pretty benign. And this can rarely cause significant bradycardia with symptoms of inadequate cardiac output or like fatigue, lightheadedness, angina, syncope, heart failure. But in older patients with acute ischemia or additional cardiac comorbidities, this can be more of a problem. In a Mobitz type 2, they're episodic and unpredictable, and Mobitz type 2 can lead to a third-degree AV block, so you want to prevent that with a pacemaker probably. In third-degree or complete AV block, this is complete failure of impulse conduction between the atria and the ventricles. In a third-degree complete AV heart block, you have P-to-P intervals that are constant. Some P waves are hidden inside the QRS complexes. R to R wave intervals are constant. There's an escape rhythm, which is an independent conduction from ventricle. So here the ventricles and the atria are basically doing their own thing. You might see that in a specific EKG there was a P QRS, but sure enough, that P is going to be firing independently from the QRS complex, and that's really bad. So EKG findings in complete AV blocks, we just said, and symptoms would be dizziness and worsening of angina. If left untreated, it can cause ventricular arrhythmias or asystole, so that's extremely bad. Symptomatic patients should be referred immediately for temporary pacemaker insertion, while detailed evaluation for potential causes is performed. So again, in third-degree AV block, no ifs, ands, or buts. These patients are going to require pacemakers as their treatment. Reversible causes of third-degree AV block would be like MIs or increased vagal tones during sleep or during pain symptoms that can cause a third-degree AV block. Metabolic disturbances like hyperkalemia can do it. AV nodal blocking agents like beta blockers, calcium channel blockers like verapamil can also cause an AV block, and it is reversible if you just stop the medication. Permanent pacemakers is going to be indicated in the absence of reversible causes, and contraindications would be like beta blockers, like we said, because it can worsen it or induce it, and digoxin that can worsen the complete AV block. Moving on, we have atrial fibrillation. So the pulmonary veins are going to be the most frequent locations of an ectopic foci that causes atrial fibrillation. That is straightforward, UWorld question, and they show you an EKG showing you atrial fibrillation, and they're going to straight up ask you, where is the ectopic foci located? And it is in the pulmonary veins themselves. Cardiac tissue like myocardial sleeves are going to extend into that pulmonary vein, and that's normally going to function like a sphincter to reduce the reflux of blood into the pulmonary vein during an atrial systole. So when the atria contract, in that pulmonary vein, it's going to constrict a little bit like a sphincter to prevent blood from backflowing into the lungs. So here in atrial fibrillation, that area is not working, and that's where the ectopic foci is. The tissue has different electrical properties that are surrounding atrial myocytes, and those are prone to ectopic foci or aberrant conductions that can initiate atrial fibrillation. This tissue, in atrial fibrillation, that tissue can be disrupted by catheter-based radiofrequency ablation in those who are unable to achieve adequate rate and rhythm control with standard medical therapy, thereby disconnecting the pulmonary veins from the left atrium. So you can actually radiofrequency ablate that area as a treatment option. There's no organized atrial activity, and impulses are conducted in a random and unpredictable manner. This is going to lead to an absence of any discernible P waves and an irregular rhythm that varies the R to R interval. In atrial fibrillation with a rapid ventricular response, this is an irregular rhythm that has narrow complexes with tachycardia with no organized P waves. The ventricular rates here can be as high as up to 150 beats per minute, and those symptoms are going to be due to fast ventricular rates rather than the arrhythmia itself. So that could be a question. Is it because of the arrhythmia, or is it because of the rate? And it's because of the rate. So again, in atrial fibrillation, there's no distinct P waves. It's irregular R to R intervals. There's narrow QRS complexes, and the atrial rate is usually at greater than 350 beats per minute. Okay, so what are some of the conditions associated with atrial fibrillation? Cardiac, pulmonary, and other causes can cause atrial fibrillation. So in cardiac, hypertensive heart disease is going to be the most common. Coronary artery disease can cause atrial fibrillation. Rheumatic valvular heart disease like mitral stenosis or mitral regurgitation. Congestive heart failure. Hypertrophic cardiomyopathy can cause atrial fibrillation. Congenital heart diseases like atrial septal defects and post-cardiac surgeries can all cause atrial fibrillation. In pulmonary causes of atrial fibrillation would be obstructive sleep apnea, pulmonary embolisms, COPD can do it, as well as acute hypoxia, like in a pneumonia. That can cause an atrial fibrillation. So elderly patients, for instance, they are at risk, or higher at risk for pneumonia, and they're also at higher risk for atrial fibrillation. Miscellaneous ones would be like obesity, endocrine problems like hypothyroidism and diabetes, alcohol abuse, that's a big one. Somebody who's binge drinking and they get atrial fibrillation. I mean, that's a test question in itself. Drugs like amphetamines and cocaine and theophylline, those can all cause atrial fibrillations. So patients with new onset of atrial fibrillation should be screened for occult hyperthyroidism by TSH and free T4 levels. So you have to check TSH and free T4 because it might be due to hyperthyroidism. Two issues that need to be addressed in all patients with new onset atrial fibrillation are going to be the rate or rhythm control strategies. So what are you going to do, rate or rhythm control? And to risk stratify for the prevention of systemic embolizations. There is no significant difference in morbidity and mortality between rate or rhythm control strategy for atrial fibrillation. But rate control is preferred over rhythm control. So remember that in a hemodynamically stable patient, rate control is preferred. Rate control is achieved by giving them beta blockers like metoprolol, calcium channel blockers like diltiazem or digoxin, and that's going to control the ventricular rate. The rhythm control, however, this would be a more serious form of control through synchronized cardioversion. Synchronized cardioversion is going to be needed in hemodynamically unstable patients with rapid atrial fibrillation. It should be considered in those who do not achieve adequate rate control or recurrent symptomatic episodes, like palpitations, if they get palpitations, lightheadedness, dyspnea, angina, or heart failure symptoms in the setting of an underlying left ventricular systolic dysfunction, then you want to do synchronized cardioversion for atrial fibrillation. And to attempt cardioversion for an unknown duration or for more than 48 hours without adequate anticoagulation increases the risk for systemic thromboembolism. So in any patient who has atrial fibrillation that you require cardioversion, you should anticoagulate them beforehand. Moving on, we're going to see what are the indications, or what are the patients who are the highest risks of thromboembolic complications, since we're on that topic, and those who will benefit the best from antibiotic therapy. So all patients with atrial fibrillation should basically be assessed with a CHADS-VASc score. And the CHADS-VASc score is simply put as CHADS, that's CHADS, and then VASc is VA, and then the SC. Okay, so the C in CHADS is going to be congestive heart failure. The H is for hypertension. A is for age, and that's age greater than 75 years old. The D is for diabetes, mellitus. The S is for stroke, TIAs, or thromboembolisms. The V in the VASc is for vascular diseases prior to an MI, or peripheral artery diseases, or aortic plaques, basically vascular problems. The A in VASc, again, is age, again, but this time it's age between 65 to 74. And then the SC, which is the VASc, the SC is your sex category, and that's your females. So here it's by score, so 1 or 2, and the maximum score is a 9. So everything is basically 1 point, except for the first A, which is the greater than 75 years old. If they're greater than 75 years old, automatically they get 2 points. And if they've had a stroke, that's automatically 2 points. So CHADS-VASc score, the first A is 2 points. The stroke, or the S, is 2 points. Everything else is 1 point. And patients assigned to one of these two categories, basically 0 is no anticoagulation needed, because that's a low score or low risk. If you have 1 point, that's an intermediate risk. So aspirin could probably be given, or you can give them an anticoagulant. You can, or they might not even necessarily need any type of anticoagulant therapy. However, if you have 2 or greater points, meaning that immediately if you're over the age of 75, you're automatically in the criteria for high risk of stroke. So you will be required to have an oral anticoagulant. And valvular atrial fibrillation or mechanical prosthetic valves, in any of those two states, you will require warfarin. Warfarin is going to be warfarin or target-specific oral anticoagulation. All patients with paroxysmal or persistent atrial fibrillation should be risk stratified with that CHADS-VASc score to assess the need for any kind of long-term anticoagulation. So remember that CHADS-VASc score. Congestive heart failure, hypertension, greater than 75 years of age, diabetes, stroke, vascular problems, aged less than 74, and female sex. And the ones that are, they're all 1 point. The ones that are 2 points are going to be if you're older than 75 or you've had a history of a stroke. Automatically you get 2 points, and automatically you have to be anticoagulated. All right, so anticoagulation in atrial fibrillation, we already said that. And then now you have your lone atrial fibrillation. That's the presence of paroxysmal, persistent, or permanent atrial fibrillation that has no evidence of cardiopulmonary or structural diseases. So patients who have lone atrial fibrillation are usually less than 60 years of age by definition, and they have a CHADS-VASc score of basically 0. So a lone atrial fibrillation, you leave them alone because they don't have any type of risk. So that's good. So what are some atrial premature beats? Atrial premature beats indicate depolarization of the atria that's originating in the focus that's outside of the SA node. So remember that the SA node is the one that first initializes the electrical conduction through the heart. So in this case, a premature beat is happening outside the SA node. They're seen on EKG as P waves with abnormal morphology, and they're often occurring early in a cardiac cycle than a normal P wave. So here the rates are going to be between 60 to 100. The rhythm is going to be irregular, and the P wave is often going to be different in shape from one another, especially the one originating from the SA node. And the QRS complexes are going to be normal because this has to do with a premature SA node depolarization. So it's benign. It can occur in healthy people and those with diseased hearts. It's usually asymptomatic, but it could cause symptoms of skipped beats or palpitations, and it could precede an atrial fibrillation. How do you treat? You only treat if the patient is symptomatic, or it can cause distress, or when there's a supraventricular tachycardia. Also, persistent premature atrial contractions with symptoms can be treated with low-dose beta blockers. Even if they're asymptomatic, there could be precipitating factors that are causing this, like if they're smoking, alcohol, caffeine, stress. All those can be identified and avoided. So in the absence of those precipitating factors, a transthoracic echo should be performed to look for any kind of cardiac, valvular structural problems or functional abnormalities. Next we have supraventricular tachycardia. So in supraventricular tachycardia, this mostly shows up as narrow QRS complex tachycardia. So if you see narrow complex tachycardia, I mean the ones that look like just spikes, that's supraventricular arrhythmias or supraventricular tachycardia. There's usually no P waves, no regular P waves, as they can be buried inside the QRS complex, but there could be a retrograde P wave that can occur, and retrograde P waves are seen in the beginning or in the end of a QRS complex when the atria and the ventricles are not simultaneous, and they can appear as spikes on the QRS complex or as inverted P waves. In an EKG that's going to show regular and narrow complex tachycardia, the QRS duration is going to be, the duration of the QRS is going to be very narrow, so it's less than 120 milliseconds at a rate of approximately 160 beats per minute. In a supraventricular tachycardia is any tachycardia that's originating above the bundle of His, and it includes sinus tachycardia, multifocal atrial tachycardia, atrial flutter, atrial fibrillation, AV node reentrant tachycardia, and AV reentrant tachycardia, as well as junctional tachycardia. Now, AV node reentry tachycardia is because of a reentry circuit that's formed by two separate conduction pathways. So both of them are going to be happening simultaneously, but one is faster than the other, and that's all happening within the AV node, causing a reentry. And then you have the AV node reentry separate from the AV nodal reentry. The AV reentry is due to a reentry circuit involving the accessory AV node bypass tract. So one of them is happening within the AV node, and the other one's happening outside the node, specifically in the bypass tract. Clinical features would be palpitations, dizziness, lightheadedness, shortness of breath, diaphoresis, chest pain, pre-syncope or syncope. So not very specific. And the next topic would be paroxysmal supraventricular tachycardia. This is a type of supraventricular tachycardia that has abrupt onsets and offsets, and they include AV node reentry tachycardia as well as AV reentry tachycardia, atrial tachycardia, junctional tachycardia. There can be a sudden onset of regular narrow complex tachycardia, and the mechanism of action here is that there's a reentry into the AV node as well. So that could be a paroxysmal supraventricular tachycardia. In patients who are hemodynamically stable, the next step is to evaluate. So evaluate is done to identify the type of supraventricular tachycardia, and how do you identify SVTs is with vagal maneuvers like carotid massage, Valsalva, putting pressure on your eyeball, inserting your face into cold water, all those little things that you've seen on the vignettes, those are vagal maneuvers. Or you can also give IV adenosine. Now, adenosine or vagal maneuvers temporarily are going to slow down the conduction of the AV node, and it can aid in the diagnosis by unmasking hidden P waves in patients with atrial flutter or atrial tachycardia. They can also cause transient AV nodal blocks, and they can terminate the AV nodal dependent arrhythmias, including AV nodal reentry tachycardia and orthodromic AV reentry tachycardia. So IV beta blockers and calcium channel blockers can be occasionally given to those who do not respond to vagal maneuvers, or if they don't respond to IV adenosine. And in patients who are hemodynamically unstable with persistent tachyarrhythmias and narrow or wide QRS complexes, hypotension, and signs of poor perfusions like cool extremities, shock, ischemic chest discomfort, mental status changes,